welcome to the Learning Collaborative. As we wait for our fellows to join here, I'm sharing our Learning Collaborative sort of mission and purpose. We always like to land on this screen and remind us and center us on why we're here today. So thank you all so much for joining. We would love to have you introduce yourselves in the chat if you'd like to introduce your name and organization. We'd love to know who all is in the room. And other than that, we'll give it just a few minutes to let people join. I love seeing the broad range of organizations that we have represented in different sectors. It's always so exciting to see who all we're bringing together today. So we will go ahead and get started here. We have a little bit of gear up content as people continue to trickle in. So I'm excited today to share our topic. We are going to be discussing drug trends in Washington State and celebrating the work that Triumph Treatment Services is doing here as well. So we are really excited. It's National Recovery Month. So this is in honor of National Recovery Month wrapping up here in these last few days of the month. But we are very excited for this topic. Our learning outcomes today, we're going to understand current drug trends in Washington with some focus on Southeastern Washington, but also looking at Washington as a whole. We're going to learn how to access the Overdose Data Mapping Application Program, or ODMAP. And then we'll learn about one organization's continuum of care model for treating substance use disorder, and understand services offered by Triumph Treatment Services and best practices for referring to them. So that's kind of what we'll go through today. And our agenda we'll start with the Northwest High Intensity Drug Trafficking Area, Amanda and Mike, and then move into Triumph Treatment Services. And we will have some time for Q&A and sort of just wrap up at the end some housekeeping items. So one of the things that we will have is a survey at the end, but we know some people have to hop off at the hour mark. So I will put the link to the survey in the chat so that you can go ahead and fill that out when you have a moment. But other than that, I'm going to shift into introducing our first two presenters. So Amanda Dutt, let me pull up my notes here. Sorry, I thought I had them pulled up. There we go. Amanda is the public health analyst on the Washington Overdose Response Strategy Team, where she works with Northwest HIDA, the CDC Foundation, and the Washington Department of Health. She comes from a nonprofit background and previously served as a prevention specialist working on fentanyl awareness and overdose prevention trainings, with an emphasis on stigma reduction among people who use drugs, school-based prevention programming, and community health outreach. And Amanda will be joined by her partner, Mike, who is currently the Drug Intelligence Officer and a member of the Overdose Response Strategy Team at Northwest HIDA. Prior to taking this position, Mr. Miser retired from federal law enforcement after 31 years of service. Mr. Miser retired from federal law enforcement. Mr. Miser served most of this time with the Federal Bureau investigating violent criminal organizations, and drug trafficking in Detroit and Baltimore. And additionally, Mr. Miser supervised the Maryland Crimes Against Children Task Force for 7 years. So I'm going to hand it over. Amanda, I believe you are going to start screen sharing.
Yes, if that's okay.
Yeah, let me stop share and let you load up your screen.
Awesome. Hello, everyone. It's great to be here today. I actually recognize some people on the call. Shelly in particular, I think you've probably been through a similar presentation like 3 times by now. Lots of overlap. Let's see. Okay, are you guys able to see my screen? If someone could just shout out, yeah. I can't
We
see.
see Amanda. Yep.
It looks great. Looks
Okay,
awesome.
perfect. Awesome. I'll get going then. Yeah, so thank you for the introductions. I'm a public health analyst, and this is Mike Meiser, my drug intelligence officer. Really briefly, we work on the overdose response strategy team. So our job is to facilitate data sharing statewide that relates to overdoses and overdose trends. Another project we do every quarter is a quarterly drug trends report. So when we compile that, Northwest HIDA has law enforcement task forces in I think 15 counties statewide. So we reach out to those law enforcement initiatives, and they're all drug related initiatives, just to see what's going on, what they're seeing, new trends in the supply and the market. And then we also have some quantitative data that we look at every quarter, which is going to be drug seizure analysis or drug price analysis. So it's a blend of qualitative and quantitative information. And the quantitative stuff is good for seeing, the concrete evidence of what's out there. Qualitative is good for forecasting trends. So not everything that we hear about necessarily turns into a trend, but some of it does. So we've condensed a lot of that for you today, and we'll just dive right in. So starting with the star of the show, fentanyl, this should come as no surprise or be news to anyone, but obviously substantial rise in fentanyl over the past couple years, starting around 2017 or so, and simultaneously a huge decline in heroin. Most of our task forces statewide have been saying they're barely seeing it, and when they are, it's just in very small amounts. We have one task force that said in 2023 they had 0 heroin seizures. In terms of pills have been the most predominant form that fentanyl has been in for quite a few years. It's going to be those pills on the right, counterfeit blue, oxycodone, or M30s as they're known. That's the most prominent form. But in around 2023 to 2024, we started to see a large increase in fentanyl powder statewide. So the start of 2024, I would say statewide, we're kind of seeing split 50-50, but our law enforcement drug seizure information still shows tablets as being slightly more predominant. And in the Southeast region and Eastern Washington especially, that's where you're still going to see more fentanyl pills in circulation being used. The fentanyl powder prominence tends to be more in Western Washington. For both of those forms, smoking is going to be the most common form of ingestion. And the market, both in terms of availability and prices, varies substantially by region. In your more rural areas, you're going to see higher price points for both powder and pills. And then in the more urban areas, it's going to be a little bit cheaper. Anything I missed on that?
No, you got it all.
Okay, great. And just I'll say I can't see if anyone's hand is up. So if there are any questions, just take yourself off mute, or maybe at the end we can take questions. Okay, looking at purity of fentanyl, the average fentanyl pill has around 2 milligrams of fentanyl. We're starting to hear more, and this is a very new trend, but that pills are decreasing in their purity and kind of getting less strong. And Mike has been hearing things to a similar effect in terms of powder, that both powder and pill supply are starting to decrease in strength, which might in turn lead to a resurgence of interest in heroin. Powder purity is highly variable, and it's also infrequently tested. I think we've only received results on powder purity maybe twice in the past 6 months. Most recently, King County Medical Examiner's Office sent off some samples to be tested, and the fentanyl powder range for Washington was about 12 to 77%. Average powder is typically around 20%, but when looking at the 12 to 77% range, that's not even the biggest range we've seen. Previous results have shown powder to be as low as 2% pure fentanyl, all the way up to 98% pure. So this is obviously an enormous risk for overdose because users don't know how strong their supply is. And both with fentanyl pills and powder, it's not like the fentanyl is kind of universally or evenly distributed, so to speak. It's possible that one part of the pill might have most of the fentanyl and the rest of the pill won't. So even kind of divvying up your supply in attempts to be safe, don't really guarantee safety because you don't know where that fentanyl might be distributed within the product. So This high variance is an enormous risk for overdose because there's just really, frankly, no way for people to know how strong their powder is. Some common substances that we see mixed in with fentanyl, especially fentanyl powder, is going to be acetaminophen, 4-ANPP, which is a fentanyl precursor metabolite, and then there's some other fentanyl analogs
Like, actually, the acetaminophen is going to be mainly in your pills.
in our pills.
Yeah.
Do you want to speak to some other analogs?
You got to pull that up.
Okay, so we have nitazines have been a little bit seen in Washington, but not quite as much, although we recently received information that
Did you want to go?
no. Parafluorofentanyl also has been seen in the supply, and King County had a couple cases of carfentanil this year. So that is the purity of fentanyl. Moving right along, methamphetamine. So methamphetamine doesn't really get as much airtime anymore because it's not changing as much in fentanyl, but it's still of the illicit drugs. So if we exclude, say alcohol or cannabis or some other drugs that people might think of the big illicit drugs, methamphetamine is still the second most common substance contributing to overdose. There's little to no change in the market. Whenever we ask about meth, not much changes. It's still incredibly prevalent. It's everywhere. And the price point, to my knowledge, doesn't really change that much, right?
No, it's been consistent for the last couple of years
Yeah.
as far as user quantity and wholesale quantity.
Do you know if it varies region? Like is Eastern different than Western?
It's a little bit, well, it's pretty consistent across the state. It's a little bit cheaper on the east side or on the west side, but still pretty close. So there's really not a lot of difference in the price.
Yeah, very reliable. To that end, incredibly high purity, and that's been the case for a while. The average purity of methamphetamine in Washington is around 97%. DEA released a report, I think it was 2024, 2023 on methamphetamine nationwide. It's publicly available, so if you want to look it up, it's very interesting. But they tested kind of purity nationwide. And Washington, for whatever reason, has the highest purity outside of the southwest border. So methamphetamine kind of crossing the southwest border is pretty high. And then the highest meth purity besides that is all the way up here in Washington, which I think is pretty interesting. And the most common form is crystal. Occasionally, we might see some other forms.
Powder, liquid. We did have a recent seizure of pills, methamphetamine pills.
Yeah, by and large, though, as you'd imagine, the most common form is going to be crystal. So methamphetamine overdoses for methamphetamine have been increasing over the past decade. So even before we really saw high saturation of fentanyl and fentanyl-related overdoses, methamphetamine overdoses like solo were still on the rise over the past decade in Washington. However, though, we do see high rates of both methamphetamine and fentanyl co-use, and oftentimes a lot of overdoses that we see involve both methamphetamine and fentanyl. So I just included this information kind of to highlight that. This data comes from crime lab and mortality data from Washington Department of Health, but it was analyzed by ADAI at UW. So credit to them. In Washington, 2022 to 2023 overdose deaths had this composition. 14.62 were methamphetamine only. 17% were other synthetic opioids, presumably meant to mean primarily fentanyl. And then 35% of them were both methamphetamine and other synthetic opioids, presumably fentanyl. So I think that's really interesting when you're looking at your priority population who's overdosing the most and at risk for overdose. They're largely people that are using both methamphetamine and fentanyl. Not really, kind of mixed or laced together, but just kind of using them simultaneously or back to back. Cocaine, we've seen an enormous increase in cocaine. I would say 2024, but maybe even end of 20.
Yeah, 2023 really started to explode, especially on the East Coast, and now it's probably overtaking fentanyl and or meth as far as the quantity coming across the southwest border and for sale in the country.
Yeah, exactly. It's not exactly like a luxury drug or something that's hard to find anymore. This is mostly going to be cocaine powder. In late 2023, we heard some reports of cocaine base or crack as it's known, but really what we're seeing the high saturation of is cocaine powder, and that's statewide. It's not really any particular counties or just maybe King County like you would think or the more populated areas.
Right.
It's cropping up everywhere. In conversation with task force partners, it's also no longer just among that typical cocaine demographic that you'd think of, like, 20s, 30s, younger, party going, using it for clubbing or what have you. It's really stretched to many demographic groups across the board.
And the cost of cocaine and fentanyl are pretty similar on the streets. However, the cost of wholesale cocaine has gone down dramatically. They're just not passing those savings off to their customers.
Yeah. Yeah, which is just a testament to the saturation in the supply, I think, at the distributor level. So, and likewise, reports of co-use with fentanyl at the user level, not really seeing it mix that much. However, I mean, like Mike likes to point out, they look similar, that it can be mistaken for one another.
Yeah.
There are instances of cross-contamination, so.
Yeah, you have to remember that a lot of these dealers are cutting their substances on the same tables, using the same equipment, same bags. They receive the shipments, so they'll receive all three, maybe meth, fentanyl, and coke, and they're putting them all in the same bags. They mix them up. We've had several cases where dealers have thought they were selling fentanyl powder, but they were selling cocaine and vice versa, which led to overdoses. Most of the things we're seeing is we're not seeing it mixed purposely, and most of it's cross contamination. Most of these dealers are not going to be trained chemists, so it's kind of potluck what you're getting. So
Yeah. Emerging trend though, so we're keeping our eye on this. Cocaine is really, really on the rise. And if you guys aren't already seeing this play out in your community, I'm sure you will very soon. Emerging substances and adulterants. These are just some things we're keeping our eyes on and that we've seen crop up lately. Mike, do you want to take xylazine and ketamine?
yeah, I'll take xylazine is the there was a big to do about xylazine, I think about 6 months ago, a year ago. It is a animal tranquilizer. It's being mixed at the user levels or at the lower levels by drug dealers to adulterate their and stretch their fentanyl product. It doesn't seem that it is related to the increase in overdoses, actual decrease actually recently, even in areas where you see a high percentage of xylazine in your fentanyl, they are seeing a decrease in overdoses. There's still a lot more studies being done on xylazine, the effects on the human body. However, there are indications, they have the sores, and one of the big things is when you're dealing with xylazine and fentanyl, the xylazine will knock you out. Most of the users describe taking a hit that has xylazine in it, and they'll notice a different chemical taste or smell. And they'll wake up all of a sudden, they just pass out quickly, and they'll wake up with like the worst hangover of their life, and they'll want more. So in talking to some of my partners in Philadelphia, a lot of the harm reduction groups in Kensington, they actually bring oxygen bottles out there with them because the people are just passing out as soon as they take a hit that is high in xylazine, and they'll use oxygen and stay with that person. First, they'll administer the naloxone, and then they'll provide the oxygen and stay with that person.
Right. And I'm sure everyone on the call knows this, but obviously, Narcan's not going to work on xylazine because it's not an opioid, thus using oxygen to treat that part of it.
But we're not really seeing it here in large amounts. I think it's about 10% of the fentanyl right now that we're seeing has it in it. Ketamine, that's an hallucinogen. It is being mixed with pretty much everything from fentanyl to cocaine or whatever you want to put it in, MDMA. So one of the things with ketamine is there is a new trend within the Hispanic community, especially the Colombians, where they mix it with cocaine, and it's a pinkish substance, and they call it Tusi, but we haven't seen it here in the state. Also, the new thing is this drug, not a drug, it's a chemical called BT-MPS. I'm not going to give you the actual chemical name. It is a chemical that's placed into plastics to keep it safe from ultraviolet light from fading. And we're finding that in some of our fentanyl samples in the last 3 months in about 11 states. and we're really not sure why it's in there and what the effects are on the human body. However, it does make the user sick, have vision issues, headaches.
All the things associated with kind of ingesting something toxic. And I think our concern for us too is we only heard about this pretty recently. And for those of you who maybe also work with DOH, I know there's some information that was spread around about this already,
Mhm.
but it kind of appeared on the radar fairly quickly. And for it, cropping up just in June of this year, had already appeared in many other states. So, I mean, it's possible maybe it was there before and people just didn't know to test for it. But it is an industrial chemical that was tested on rats for some potential benefits or uses and kind of moderating the administration of morphine, but it has no approved use for humans, and it's highly perplexing, but cropping up in the supply.
According to the users, when they do smoke it, it smells like bug spray.
Lovely. I'm gonna move this along just for time.
So that's one thing we're looking at. This just may be a one-off. There may be we just don't know. It just started in June, so that's something we're watching. And also adulterants is not on here is the nitazines. We are seeing that pop up. It's mainly coming off the dark web. That is another
Fentanyl analog.
another opioid.
Oh, okay.
Another opioid, which they're mixing with the fentanyl to increase the strength of the fentanyl. But that is mainly coming in through the dark web right now, so we're not seeing large amounts of it.
There were a few instances kind of in central Western Washington earlier this year. In terms of trends in psychedelics, I mean, mushrooms, DMT, ketamine, all of those things have been on the rise. I think just locally, regionally, and there's a lot of public interest, right? Ketamine, DMT being tested for use in depression and other disorders. We have seen some increases of DMT, especially now being sold in vape form. And Mike was saying a while ago, but there is a lot of DMT crossing the southern border of the US right now, which I think is really interesting. Mushrooms, kind of, similar increase that's just been reflected regionally and nationwide, but nothing huge spike that's Washington specific, except for some stuff related to youth use, which we're going to get into right now. So as part of this past quarter's report, we wanted to kind of take a temperature check on drug use and overdoses amongst youth. So we asked our normal task force partners what they knew about kind of what the kids were up to, so to speak. Are they using fentanyl? Are they overdosing? What are they doing? So we received information from them, but then we'll also put in contact with school resource officers statewide and did interviews with them as well. The big takeaways are kind of what you would expect, what we all know kids are using, which is cannabis, THC containing products, vapes, and then alcohol is going to be the most common. It's important to emphasize, first of all, it's important to emphasize that the majority of youth aren't using drugs, right? Like good prevention programming is highlighting that most kids are actually not using drugs. If they are, it's usually those top 3 substances. Opioids and harder drug use is incredibly, incredibly rare among middle schoolers and high schoolers. It's obviously very scary, and I think when we hear of it, we focus on it a lot, as we should, but it's still incredibly rare. Mushrooms, we did hear from 1 or 2 partners are kind of on the rise with youth, but it's specifically this one, the Amanita mushroom, which is sold over the counter in smoke shops and marketed as a legal magic mushroom. And then it's also simultaneously, they tell you have to take a higher dose to have the effects of a psychedelic mushroom. So these can be bought probably in gas stations, smoke shops, and are popular with youth. One reason we bring it up is because if you haven't seen, there was an FDA recall on a lot of Amanita mushroom products this year. In Washington state and nationwide, there's been quite a few severe illnesses and maybe even a death linked to the Diamond Shrooms brand of Amanita mushrooms. So I think that's something to really keep your eye on. Increase in youth overdoses. So this is Washington Department of Health information. But from 2016 to 2022, overdose deaths among 14 to 18-year-olds, this rate tripled from about 4 per 100,000 people to around 10 out of 100,000 people. And then specifically, those overdoses are increasing among very young children, particularly even children under 4. And in those instances, it's cases of accidental ingestion in the home environment, fentanyl pill, looks like candy, stick it in their mouth, that sort of thing. One challenge we heard a lot when speaking to school resource officers is just how ubiquitous vaping products is, and that, students are using vaping products and THC products in the school setting. And there's really no means of intervention or consequence or way to kind of regulate it. So just how saturated kind of the school surrounding has become with vaping products. A lot of sales of drugs that kids are engaging with is happening over phone applications like Snapchat and Telegram. Other instances where they're getting it in person is going to be from their peers. So preliminary decrease in overdoses, we are seeing a preliminary decrease or plateauing in certain areas in overdoses, both nationwide and at the county and state level. This is just some information I kind of pieced together to give you sort of a snapshot. So in terms of fatalities, King County Medical Examiner's Office puts out a statewide monthly bulletin on fatal overdoses that compiles a lot of county level information. So looking at their statewide bulletin from January 2024, so the start of this year till currently, overall a 4% decrease in fatalities statewide, but that only includes about 20 counties that they can receive information from. In King County specifically, the year period has seen a 19% decrease in fatalities. Looking at EMS responses for overdose events, there's been a 4.4% decrease in non-fatal overdose responses in King County. And then when looking at WMSIS data, there's been a 35% decrease in suspected overdose responses in Washington for the past year. WMSIS data typically captures anywhere from 90 to 95% of responses, so it's not all information, but it's the lion's share. Emergency department visits for overdose events. When looking at CDC information from their dose dashboard, there's been a 10.6% decrease in ED visits for all drug-related ODs in Washington for a year period, June to June. And then that is also 9% when looking at opioid-related overdoses.
Going back to King County, we're down about 20% from this year compared to last year's numbers. That's specifically with King County. Also, you're looking at an overdose fatality rate also decreasing in British Columbia, Canada, and actually across the country, looking at about a 10% decrease.
Yeah,
the country.
The decreases nationwide are even kind of more substantial and more easy to see in the data. And I will just also say, looking at preliminary overdoses can be tricky because a lot of those really official records don't come out for, at least a year. So we're kind of having to use different sources to quantify and legitimize what we're seeing as a decrease. So I know we're probably low on time, so I'm going to speed through everything else. And then Danny, if you have to cut me off, just come off mute and do it. You won't hurt my feelings. Another thing that we do at HIDA in general, we have a program called ODMAP, which is the Overdose Data Mapping Application Program. So this was developed by Washington, Baltimore, HIDA, and it is a map-based tool that tracks overdose events in near real time. So this is a kind of a snapshot of what the national level engagement looks like, those yellow areas being areas that are using ODMAP and active. ODMAP is for fatal and non-fatal reporting of overdoses. And we really like to stress that it's near real-time data because, if you find out about a spike in overdoses in a particular county area, what have you, 6 months after the fact, that doesn't really serve you. You can't mobilize around that information. So having this information as near real-time as possible is important, especially for our, harm reduction and community-based organizations.
One of the things with the map there, just to update it, Idaho is fully engaged. They have an API where all their EMS information is going into ODMAP. California is going to be doing the same shortly, as is Oregon.
Yeah, there are some states where it's mandated that all EMS data has to go in. So you see their state will be completely yellow, which is great. Washington is not one of those states, unfortunately. So we've been trying to kind of onboard different agencies at the county level for a while. So it's free to use. There are some stipulations around, like if you already have systems of record, there could be a cost in terms of implementing an API. And it's HIPAA compliant. So I will say the only 4 data points that have to be reported into ODMAP for an overdose event are going to be the location, the time, and the location is geocoded. It's never the exact location. You can't zoom in and see exactly where it happened. Time, was it fatal, non-fatal overdose, and was naloxone administered? So it's HIPAA compliant, no personal identifying information is stored within the system. Eligible agencies, everyone with the .gov, law enforcement, public health personnel, the federal, state, local. This includes ME coroners, first responders, hospital with EDs, and everyone signs a participation agreement prior to gaining access. So we're all kind of, understand the limitations of how we can use it. Just a snapshot of Washington engagement, although this is going to be like a week old or so, maybe 2 weeks old. A big challenge in Washington, like I said, is partial reporting. It's not required to submit to ODMAP, so we don't have a complete picture of overdose events in the state. Not all jurisdictions or counties are online. Currently, there's 75 agencies using it in Washington, and this is a snapshot of what the statistics have looked like so far. So for Q1 2024 statewide, about 2,000 total overdoses, 400 of which were fatal. Q2, again, about 2,000 totals, 411 were fatal. Q3, although not complete Q3, we're down to 1,000 total and 155 are fatal. Obviously, this is just for counties that are reporting. Statewide, if everyone was reporting, there's going to be a lot more.
Our main three are going to be Yakima, Benton County, Tri-City area, and Seattle are on board as far as APIs. And we'll get Skagit's coming on board, and we have also some other counties which are coming on board.
Jamie, do I have time to switch us over to a quick demo or snapshot?
Yeah, you're good.
Okay, great. So I am going to take us here. This is what the map looks like. Hopefully you guys can see it. Yeah, I'm gonna assume you can, because I haven't heard otherwise. Awesome. So this is what the map looks like. I'm zoomed into Washington right now, and I have it filtered to Washington because it takes a while to load. So if I wasn't filtered into Washington, the whole nation would light up like a Christmas tree. But looking just at Washington right now, I have us also set for the quarter. So down here, you're going to have default summary statistics. There's been 1,115 suspected overdoses this quarter in Washington, 163 of which were fatal, 232 included naloxone administration. This metric is not really reliable because not everyone reports it the same way. So there can be some discrepancies in the naloxone. Each little data point corresponds to a different type of event, which typically you can see right here. So the diamonds are going to be fatal overdoses, circles are going to be non-fatal, and then color corresponds to naloxone administration. So that's always there. This is your filtering panel. So I have it for Washington, and then you can zone in by county. There's preset time frames that you can choose to see, when overdose events occurred. If you want to see fatal or non-fatal, and even if you want to see zip codes or agencies that are inputting, you can put all of that there and apply your filters. Over here as well, you have kind of some graphs and tables that can be generated. The table is just going to be a list of overdoses. This can be good if you want to get contact information of the agency that's inputting particular overdose events. And then here we can generate some tables based off this information. This is a feature that can be really useful if you're going into a meeting with kind of stakeholders and want to show trends for your area on overdoses. So here we have overdoses by type, day of the week, hour of the day, some other options too that can be exported and used in presentations. I just want to highlight, obviously we see some areas of engagement, which is great. And then we see a lot of areas where there are no lights at all, which should not be construed to mean overdoses are not happening here. It means that we don't have agencies reporting in these areas. So we have pretty good engagement in Tri-Cities area, yay, Yakima, yay. King County, Snohomish, and Skagit are pretty great users of it. Let's see, some other features I just want to show you quickly is going to be, we can kind of zoom into Yakima if we want it. Again, these are going to be fatals and non-fatals. What can be useful, maybe we'll go to Tri-Cities where there's a little more. What can be useful when looking at the data is to apply a heat map and see kind of where your saturation of overdoses is. It's kind of easier to digest than all those data points. So if you want to be able to say advocate for allocation of resources to a particular area, this map can be useful to pull out and see like, hey, in this, I'm sorry, in the Pasco area, we have a higher saturation of overdoses happening. Maybe we need to focus our naloxone distribution efforts there, put more, bodies there. Like, what do we need to do to enhance this area that we can see as high need via the heat map? Another thing you can do with the heat map is add different layers, right? So we can add public schools and then have all public school locations populated on this map or other landmarks. I mean, you can also use your own GIS layers like crime data and see based off landmarks or your other maps, like where are these saturation of overdoses happening, right? So if a school falls right here within this saturation area, we know that's a school we should reach out to and kind of see if they need assistance in overdose response or how they can be supported. So that's just a quick overview of the map. There's some other features too that I can show, maybe one-on-one demos when we're not kind of shorter on time, but really the best way to use OD map, besides just kind of the joy of looking at data and seeing what's going on, is going to be through utilizing spike alerts. So OD map has the capacity to generate for your county, for your city, for your area, what is, quote unquote, a normal amount of overdoses is a 24-hour period for your city. And if your area goes over that amount and there's an unusually high spike in overdoses for a 24-hour period, you can receive email notification that your area is in an active spike. So they're really easy to set up. And the nice thing about this too, is you can send spike alerts for your city or your area to other public health partners or coalition partners or community-based organizations that are doing overdose prevention work or outreach, but maybe aren't eligible to have an account themselves, right? So a spike alert, you're just gonna select your state, your county. If you want to have, however, I see your hands raised, I'll get to in 1 second. Fatal, non-fatal. And then just put the email addresses of people you want to know that your area is in like a heightened, elevated amount of overdoses. We like to have spike alerts set for like Portland and other areas along the I-5 corridor. So if there's kind of a bad batch in drugs that's leading to an increase in overdoses, we can assume it's going to come up the I-5 corridor and eventually hit us. So that is one way to really utilize OD map. And then Everett, if you want to just come off mute, was it a question related to OD map before I stop sharing
Yes.
my screen?
Yes, it was a question from Shelley Little of Benton Franklin Health District, who was asking in the chat, who can we share the odd map with? Currently, we only share this with our fatality reviews. Can we share it more broadly?
Yeah, so the information from OD map is on a need-to-know basis and only certain agencies are eligible. So if you work for government agency, law enforcement, or public health, that kind of the local, state, and federal level, you're eligible, as well as like, first responders. But outside of that, you probably, like your community-based organizations aren't eligible for an account. This is considered, though it's not, personal identifying information, it is considered sensitive information.
Right. Shelley works for the health district, is what I'm just reading her comment from the chat just to make sure you saw it. She was asking.
Oh, yeah. No, I appreciate that. Yeah, Shelley, I know you have an account, and for purposes of OFR, if there's information from here that you want to use, you can use the information. You can kind of take information from OD map and share it in those settings, right? So if you're in stakeholder meetings or in meetings with decision makers who benefit from the data from OD map, you can absolutely share it. Yeah. And especially in OFRs where people sign those NDAs. Go ahead.
Amanda, this is Shelley. I do share it in OFR. I was at a community meeting the other day and Pasco Fire was sharing their map in a large format printer type situation. And I believe that they can do that because it's their data, right? That's fine. But then they look to public health to say, you have everybody's data. How come we can't see everybody's data? So I'm curious about
they
the
can share your
shareability,
information, obviously, yes.
because Pasco has 2 people reporting to that system. They have fire and police. So to me, I'm just curious who gets to make that call.
Yeah, so every agency who's using it has right to their own information that they put into it. So all overdoses that Pasco Fire is putting into OD map, they can share that. But there would need to be a data sharing agreement between other agencies. So like other agencies that aren't Pasco Fire, we need to get agreement from public health to share that information and vice versa.
Got it. Yeah, I know. Okay, sounds good.
Yeah, and we can chat more offline, Shelley, if there's more to that that we want to troubleshoot. That's awesome. We can do that.
In the interest of time, I'm going to lead us in thanking Amanda and Mike for their wonderful presentation. Thank you for all that valuable data. Is so helpful. And we will have a little bit of time at the very end for questions. So if we have, we will. But I am excited to share my screen again and introduce our next few presenters from Triumph Treatment Services. We have Renee Coleman. Renee Coleman has been the Director of External Affairs at Triumph since 2022 and has led a team that has raised nearly $26 million to support the expansion at 2 facilities, renovation at 2 other facilities, and support critical innovative programs that help support long-term recovery. In addition to her primary role in development, she also oversees all of communications and marketing, public relations, government relations, and outreach efforts for the organizations. And then Renee will be joined by her colleague Tara. Tara Hoverson is the Outpatient Services and Quality Director at Triumph Treatment Services. She's worked for Triumph for 4 years and enjoys serving clients in a supportive role and loves spending time with her fur babies, Charlie and Harper. So welcome, Tara. And finally, from Triumph, we have Cassidy. Cassidy Leslie has worked within the field of substance use for the past 7 years. She started out as a counselor in training and has had the privilege to move into different positions throughout her career, which allowed her to work with a wide variety of patients in different settings. Currently, she is the Clinical Director of Substance Use Disorder Services, which gives her the privilege to work with those who struggle with a substance use disorder in a different way, while also working to educate individuals on what a substance use disorder is, as well as the importance of treatment. So thank you to the 3 of you, and I will continue to screen share and just let me know when you're ready to advance to the next slide.
Great. Thank you, Danny. And we can start with our first slide there, which is a fun collage of all of our staff. But while we kind of leave some smiling, joyful faces there, Amanda and Mike, I want to thank you for that really interesting presentation. While we were preparing for this last week, I mentioned to them how excited I was to hear their work and really appreciate hearing that statewide perspective and that really important data pull. My name is Renee, and I'm the Director of External Affairs. Thank you for that great introduction, Danny. What we're going to focus on in this portion of the presentation is just one behavioral health organization's approach to helping address those issues of addiction and generational trauma in our communities here in Washington State. And that, of course, is of Triumph Treatment Services. All of the images you see here on the slide are our counselors, our recovery support staff, our PCAP staff members, our housing case managers, our admissions team. And one of the things we really pride ourselves on at Triumph Treatment Services is creating a culture of recovery through heart and integrity and inclusivity and excellence. If you're interested and you're in Yakima or sort of the Yakima County area in learning more about this OD map work piece that Amanda was sharing, I really encourage you to connect with Alicia Strami-Tobin over at Safe Yakima. She's a great community collaborator with us and several other first responder organizations. And just as a transition key out of the last presentation, we deal with we engage with so many families and individuals who've been affected by overdose. This past year on August 30th, we hosted our 7th annual Overdose Awareness Day. We had 240 people, at least that's the people we counted, who showed up. And we had about 7 or 8 presenters share their stories. And these were stories of loss. They were stories of hope, people who had an overdose themselves and were looking ahead at hope and new life, and from professionals and elected officials about ways to affect change in our communities. You can go ahead and go to the next slide, Danny. And so really what this next portion of the presentation is focused on is this concept that we do recover. At Triumph is a behavioral health organization. We're based in Yakima County. We do serve the entire state, and we primarily provide substance use disorder services as well as mental health services and other services in a full continuum of care. We've been in the community for just about 62 years. Started as an outpatient clinic, a really small room off Natchez Ave where we had groups. And one of the things we're most proud of is that we continue every year to respond directly to our community's needs. And a lot of that response is around family reunification and innovative programs that help keep families strong and together, and moving past addiction and trauma. And our mission is really support all of those who desire to make changes in their health and quality of life. And we really mean all. So it's really important to us. I'll show you in a minute our kind of demographic, but it's really important to us that when someone is ready to make a change in their life, they have the ability to, regardless of where they are or when they need it, or if they have the right kind of insurance. It's important to us that people get the help that they need. We do this through evidence-based services, innovative programs, and a legacy of family-oriented treatment options. And hope and new life is our tagline, where hope and new life become possible. And that happens in the heart of community. So Danny, you can move to the next slide there. This is Edna and her two kiddos. And Edna came through our Pregnant and Parenting Women's program. Cassidy's going to talk in detail about that in a little bit. But I wanted to share a quote from Edna's story with you. It is on our website and in our annual report if you'd like to read her story more fully. But I just think this is such a simple and beautiful representation of the why. So Edna says, on May 21st, 2021, I entered Triumph for a 6-month program. I remember sitting outside, waiting for my intake, and just taking it all in. When you're in addiction, it's like everything is gray. But when you're not using, you see all the colors. The leaves were vivid green, and I could hear the mourning doves. I think for so many of us who don't know what it is to struggle in active addiction, we forget that the leaves are green, and we forget that the sound of mourning doves is special. And Edna is a great example of the reason we do our work. And her story is represented by all of our clients over and over and over again. To that point, the data points that you see off to the side, this is sort of the picture of who we serve. So we are based in Yakima County. We have one facility in Buena. All of our other facilities, outpatient clinics, and administrative offices are in Yakima, the city of Yakima. However, we serve all 39 counties, and Tara, in her presentation, is going to talk about how we're transporting clients to help them get to treatment when they need it and when we're the right fit for them. We serve about 2,000 clients in any given year, 1,992 clients in 2023. And who are our clients? These are the people who are most vulnerable. A lot of our clients are part of the unhoused population. A lot of our clients are on the verge of homelessness. 96% of our clients in 2023 utilize Medicaid services. So we're serving some of the most vulnerable, low-income, poverty-ridden population in our state, and we do that with a lot of care and love. One of the things that I want to say here before we transition on is we do all of this through a significant web of partnerships. And Cassie is going to talk more about those partnerships and the why and how they work together. But these are partnerships with other providers who do similar work, because we can't do it all. This is too big of, we saw the OD map. This is too big of a problem to address with one organization or with one modality. So we partner with healthcare organizations like Yakima Valley Farm Workers Clinic, Children's Village, that's a special needs child clinic, outpatient clinic here in Yakima. We partner with our local university, Pacific Northwest University, with People for People, who helps us fund our transportation program. The list goes on, and we're really proud of those partnerships. Annie, we'll pop over to our next slide, where we'll show you a highlight of our service lines. So I call these our service lines, our 5 buckets, if you will, of different services that we offer. And one of the reasons that we really believe the continuum of care model that Triumph has works is because it's not just treatment. It's not just substance use disorder treatment. It's also mental health. It's also housing. It's also long-term case management through the Parent-Child Assistance Program. And it's also peer support services. And so all of these programs, we could do an hour-and-a-half presentation in each of them in their own right. But they all weave together to help support the one client. And so Edna, back to Edna's story at the beginning, she is a great example of a family who utilized almost all of these services. She actually went through our programs a little bit before we really had our peer support up and running. But she used the entire continuum of care. And so she was able to stay in one of our services for just over 3 years. And that really helped engage her in that long-term recovery. I think let's go ahead and pop over to the next slide here, Danny. And I'm going to do a really brief overview of some of our supportive services. And then Cassidy's going to do a deep dive into our residential services there. So this outpatient substance use disorder, this is our core competency. This is where we really shine and how we step first into the behavioral health world. So we have outpatient center, SUD outpatient center here in Yakima downtown. And in that area, we provide both individual counseling as well as group counseling, but we tag peer support along with it here because it really, the peers work really closely with our outpatient counselors. So a peer certified peer counselor is someone with lived experience who can walk alongside a client or an individual or someone contemplating treatment, maybe who's not already enrolled, and help engage them and build rapport and build a relationship along the way. The peer support team is really one that helps reduce barriers for folks. They're doing a lot of street outreach. They're doing a lot of outreach in our parking lot. They're going to Camp Hope and engaging folks who are in the outdoor shelter there. And they're also working with our clients in the outpatient setting who aren't a part of PCAP. And so let's talk a little bit about PCAP. This is the Parent-Child Assistance Program, and it's a 3-year case management program that's actually based out of the University of Washington. So we were so lucky to be the 3rd host site for PCAP here in Yakima, and we're really proud of this program. It has incredible outcomes for the women that it serves. In a 5-year period that ended in 2023, PCAP had documented 159 clients that successfully completed the program. And out of them, 97% were in or had completed a treatment program. And some of them were in our treatment programs and some of them were in others. And that is the case for several clients that we work with. But I think the key there is that it's really a home visitation and case management model that meets people where they're at, focuses on harm reduction, but also has real outcomes for long-term recovery. The other stat that I love at that end of that 5-year period for PCAP is that at the end of their exit interview, 63% of those 159 clients had stable housing, which is great, but it's exceptional when you compare it against the number of 17% that had stable housing when they went in. So over the course of 3 years, PCAP is really helping to create a stability in long-term recovery. Housing is another critical supportive pillar for our continuum of care. We have 72 units. And they're in 3 different types of programs, really. So emergency family shelter, it's a relatively short-term stay, 30 to 90 days. Transitional housing and permanent supportive housing. One of the best pieces about having our clients go through the housing program, apart from the fact that they get more of that case management. So it's really a hands-on program, and they're building a community of like-minded people that they're living with. Some of the houses are community living, some of it they have individual apartments. But one of the key things is that when they successfully complete the program at the end of 2 years, they receive a Section 8 voucher. And so they can take that voucher throughout the state. So a really big benefit and incentive for folks to keep up with their treatment programs and keep up with their own personal goals. So last here, before I let Cassidy take the rest of our programming, is our outpatient mental health. This is a brand new service line for us. We opened it up about a year ago, and it is a little bit different than everything else we offer. So Cassidy will talk about how we offer co-occurring mental health in our residential treatments. But in the outpatient setting, you don't have to have a substance use disorder to call and get a counseling appointment. We've got individual one-on-ones, we've got family-oriented therapy, and even telehealth options, and qualified wonderful mental health counselors in 2 locations, in downtown Yakima and sort of in Midtown at our new Genesis building. And so we're excited to see this service line grow, because we know from our partners and from what we're hearing in the community, there's just not enough access to mental health. And this piece is one of those upstream elements that really helps us as a community move towards prevention in the long term. And so we want to also be a part of that solution. So Danny, I'll let you prompt to the next slide, and Cassidy, our clinical director, is going to talk about our residential programming.
Awesome. Thank you, Renee. I really appreciate that. Hello, everyone. So I have the privilege of kind of explaining all of our services and all the really great work that our staff do day in and day out, as well as brag about our patients, which is some of my favorite things to do. And so at Triumph, we have 5 inpatient treatment facilities. And I'll just kind of go through all of them. One of them is our men's inpatient treatment facility. That's a facility out in Uena, Washington. And from those of you who aren't from this area, that's about 25-30 minutes outside of Yakima. At that facility, we can hold up to 60 men out there, which is just a wild, crazy, chaotic environment, but it's always just a blast out there. Those gentlemen are there anywhere from 28 to 30 days. And while they are in treatment, they are receiving both SUD treatment as well as mental health treatment if they desire to. They engage in groups and classes, one-on-ones, and then as well as some case management to set them up with services once they leave treatment. And then we do have an intensive inpatient women's facility, which is here in Yakima. That facility right this moment is on our campus, and that facility can hold up to 16 women, with one of our other facilities that's a little bit up the road from our campus being Inspirations. And at that facility that we are currently under renovation, that facility was holding 16 women before. However, we are entering into a 2-part project, and in phase 1, we will be a 32-bed facility, and then in phase 2 will be a 48-bed facility. Those women in those programs are also there 28 to 30 days. It's very similar to the men's facility, where they receive SUD, mental health, case management, one-on-one group therapy, all of that while they're there. In those programmings, it's called intensive inpatient because that's exactly what it is. It's intense. So they're in programming from 9 a.m. to 4 p.m., 7 days a week. It's a very quick process. 28 days may seem like a lot of time. However, when trying to work with a patient, it's a very quick turnaround process. We do a lot of triaging in those moments, just trying to find the biggest barrier that they're facing and helping them work through that barrier, and then continuing their treatment and lower levels of care. Oftentimes patients who enter into those facilities, they are still experiencing symptoms of withdrawal. So it's a little bit harder to get them to engage right off the bat. And then once they fully move through those symptoms of withdrawal, we're able to work with them a lot quicker, or a lot more in depth. And then really kind of towards the end of their treatment, they're really focused on next steps, because like Renee said, a lot of individuals that we're working with, they enter into our program without housing. They don't have strong family support systems, and they come from all walks of life. So we really try to do anything possible to make sure that they are set up for success when they walk out of our doors. And so those are kind of our intensive inpatient programs. And then we have our pregnant and parenting women's program, also known as PPW. I'll try my best not to speak in acronyms throughout this process, but if I do, I apologize. At these two facilities that we hold these individuals at, those women are there anywhere from 4 to 6 months. It's a really just unique experience. There are not a lot of treatment facilities in Yakima that serve this population. And so we at Triumph are really privileged to work with these individuals. But we have a total of 30 beds available. One facility is able to hold 16 women and 16 kiddos, and another facility is able to hold 14 women and 14 kiddos. And so those individuals, when they enter into treatment, they can have their children with them. They can work on reunification with their children. Some moms never have their kiddos placed into their care. Some enter in pregnant and end up having their babies while they're in treatment. It really just varies on what the cases look like. We do accept kiddos ages 0 to 5. So lots of baby toddler time, which is always a good fun time when needed. But because those women are in treatment with their kiddos, the programming looks quite a bit different. Our women typically are programming from 9 to noon every single day. And then in the afternoons, they are in more specialized classes depending on where they're at in their treatment. We do provide childcare services for the moms and kiddos as well. So that way the moms can focus on their treatment while they're there. And with us having a longer time with those patients, their treatment looks significantly different in the sense of we're able to set up more stabilized housing for them. We're able to get them more stabilized on their mental health. We're able to go a lot deeper with the roots of their addiction and working through some of those past traumas that they have experienced, and really see them grow and blossom throughout their stay. I'm going to throw this out there, treatment in 28 days is really hard to hit. If there is a way that Washington State could move to where treatment is a 60 to 90 day model, there would be significant progress made in the struggles that we're experiencing, because once individuals really start to get their head clear and able to identify what they want to work on, is right about that 30-day mark. And so anyways, that's just my little throw out there. But Danny, if you want to go ahead and go to the next slide. So one of the biggest barriers that we face with addiction is the stigma around addiction and what that looks like. There's still a lot of stigma within the community and just society in general. And so one of the biggest things that we talk about is speaking about addiction, putting a name to the disease that individuals are struggling with, and making individuals understand that addiction impacts everyone. It does not discriminate against anyone or any population, and just making it, it's normal. It's normal to speak about it. It's okay to struggle, and it's okay to ask for help. And we're going to be here when you need that help. We're going to be here to invite you into treatment, and we're going to walk this journey alongside of you. And so, teaching the patients to be proud of who they are and to not be shameful of sharing that they are in recovery and what that looks like. There are a variety of different modalities that we utilize within treatment. I won't go too much into that unless individuals are interested. But one of the biggest things that I want to speak about is fentanyl. Fentanyl has really changed the field of substance use. I myself started in this field as a counselor, and I say all the time that the patients that I was working with 7 years ago are nowhere near the patients that we are working with today. Patients are a lot sicker than they were before, both mentally and physically. People are struggling with just more complex issues within their addiction. Fentanyl is easier to get, so we're seeing relapse rates happen pretty quickly, and that rate has increased significantly throughout the last couple of years. However, it has it has allowed us as clinicians and as treatment organizations to really start thinking outside the box. The models that we used to use 20, 15, 10 years ago are no longer the models that are really working. So we've had to get creative, and it's allowed us the privilege to look outside of just substance use treatment and what that looks like. And so Renee briefly talked about partnerships. And at Triumph, we love to invite everyone to come partner with us, and we'll get really creative on how we partner with those inside the community. And so there are some really big partners that we've established throughout the last couple of years. And one of those being through PNWU's occupational therapy program. We've recently, and I mean very recently, as of May of this year, has started an occupational therapy program for our pregnant and parenting women. And so what that looks like is they have their occupational therapist, Dr. Patanyak. She comes on site once a week, and she brings a couple of residents with her throughout their different cohorts. And they do groups with the patients and teach them about occupational therapy. And then for those who are interested, they're able to complete an occupational therapy evaluation. And then the team is able to implement intervention. So it's really a new form of treatment that Triumph is partnering with PNWU to try out. And then this is actually being implemented across the state of Washington in 5 other facilities, which is really exciting because it's allowing us to help patients in ways that we've never been able to help and support patients in their recovery. And it's so important that we treat patients as a whole while they're in treatment and while they're going through their recovery process. We also work with Children's Village, as well as Farm Workers Clinic. There's just, the list goes on and on and on. And without our partners in the community, we want to be able to do what we do. We are not the experts in everything, and we don't want to be the experts in everything. Our patients get kind of sick and tired of hearing us talk to them all the time about everything, and they love when new faces and new voices come in and share their time and share their expertise for a variety of ways, or for a variety of different reasons. One, they get to learn about all the amazing resources that we have, but also it shows that there are other individuals out in the community who care about who they are, and making them feel human and showing the importance of their success within our community and what that looks like. If you want to go ahead to the next slide, Danny. So kind of like I spoke about, building rapport is just such an important part. A lot of times when individuals walk through our doors, they're so broken. They feel hopeless. They oftentimes aren't proud of who they are. They really struggle with some trauma that they've experienced, and oftentimes struggle with making eye contact. Their heads are hanging low, yeah, just struggling. And so at the door, we make sure that we introduce ourselves to every single patient that walks in with a smile on our face, and just telling them how grateful we are that they are in treatment and that we get to walk along this journey with them, because it's such an important journey, and it's such a privilege for us to be able to walk that journey with them. And so one of my kind of favorite stories to share is in all of our inpatient treatment facilities, we start group off with a very specific saying, and I'll just say it as if I was in a group setting. But they start off with saying, "My name is Cassidy, and I'm a woman worthy of love, honor, trust, dignity, and respect." And then at the end of that, I would pause, and my group members would stop and say, "Yes, you are." And with that phrase, it's a very hard phrase for them to say when they first come in the doors, because they don't believe it. And they struggle with connecting with that phrase. And a lot of times, even in 28 days, when they get close to the end of their treatment, when they say that phrase, they start to smile. They hold their head up high, and you can see them start to believe that. And it may seem really subtle, but it's just a really cool experience to see, because not only do our patients do that, but we have our staff do it in group as well. So that way the staff can see that we are human also. And we need to build ourselves up, and it's just a way for counselors to connect with the patients, which is really cool. But building rapport isn't always just inside our treatment facilities. We also do have an amazing team with our peer support, and they do a lot of outreach work, because that rapport starts before the patients even come into our doors. There's a lot of individuals out in the community who don't know how to get into treatment, who don't know the proper steps to maybe meet with a doctor or how to start housing, or maybe they don't know where the food banks are around Yakima. So our peer support team does a lot of outreach work to try to get individuals connected into the service, into any services around Yakima. It's not just Triumph services. They also build rapport with our community partners, and just making sure that they know that there are people out there who care, who want to see them succeed and get them into services around the community. And so on the next slide, what you'll kind of see is a map of Yakima County. One of our peer support employees took it upon herself to outline different zones within Yakima. The colors mean nothing, just to identify that there are different areas. But there are different areas that they focus on each week just to go reach out to individuals. Just a lot of times it's just a, hey, how are you guys doing? Are you hungry? Do you need any water? Maybe we had some extra socks that week, so they're handing out socks, but then they're handing out little pamphlets for the patients and letting them know, like, if you need any help or any support, we're here to help you. Please come see us, and walking that out. And one of the really cool things is this was shared with some of our one of our county commissioners and their outreach team, and they liked this idea and are going to start implementing some of these processes. And it just goes to show, like, the importance of connection with one another and being able to help and support each other throughout this process. Because like Renee said, it's not just Triumph. It takes an entire village to support individuals and make sure that they are getting the services that they need. I could talk all day long, but I'm not going to. So I'm going to go ahead and pass it off to Tara Hoverson, who can explain the importance of low barrier treatment and the amazing work that the rest of our team does.
Thanks to Cassidy and Renee. You guys did an awesome job of explaining services at Triumph. Jenny, can you move to the next slide? Okay, so as both Renee and Cassidy explained, it's really important for us to meet clients where they're at and help them make meaningful action, take meaningful action in their recovery journey when they're ready to do so. When they come to us and they express their needs and desires, we really need to be able to jump on that while they're in that preparation stage of change. So we have to ask ourselves regularly, how can we do this? One way that we have found is we can reduce the amount of time that it takes for a client to get into services. We can connect them to other resources available if they do have some wait time, and we can help them get to treatment. And so I'm going to talk about those things today. In our outpatient services, one thing that we can do is we are having clients come in for walk-in assessments rather than having them schedule out. And so they still have the ability to schedule out if they need to do so, but they can walk in, ask for help, and get that same day. We are also providing transportation services for residential treatment. We've found that about 60% of our clients travel from outside of Yakima County to our residential treatment facilities. So in 2023, we drove 75,884 miles to pick up clients. And that was about 430 clients that we were able to transport to treatment. We pick up in several locations in Western Washington, and we do that 4 days a week. And we also provide local transportation to treatment as well. And we work with community providers like Advanced Northwest, who provide recovery navigator services in Okanogan County to get clients door to door. Speaking of Advanced Northwest, this year we were really happy that Triumph was able to receive the Helping Hand Award, which you can see up in the right-hand corner of this slide, for helping clients get to treatment, and the collaboration that we had with Advanced Northwest. We were able to help an estimated 100 clients get to treatment in the last year from Okanagan County, a super rural, hard to serve area. Another way that we are able to do that is for residential treatment, oftentimes clients are required to have an assessment to start the process. Many of our clients have been through that process many times. They know when they need residential treatment, or they've tried outpatient, it doesn't work, or they just can't stop and they know that that's the level of help that they need. Rather than requiring every client to have an assessment before they come in for treatment, our admissions team is able to work with clients to quickly screen if they meet our level of care and then get them into that level of care. All clients receive an assessment in residential treatment once they get there. So we try to skip that first step of requiring it before they come. Referrals for treatment come from a variety of sources, to include, like I said, a self-referral. Peer support often is the first step, and so peer support refers often. Recovery navigator programs from across the state help to get people into treatment. Primary care physicians, Department of Corrections, DCYF, and other behavioral health agencies. I'm going to go ahead and go to the next step. Slide, please. I just want to talk briefly about the Genesis outpatient mental health program, that the expansion of our mental health program services at Genesis. This building just opened this last year, and we're really excited to be able to offer services through there. And we are accepting clients regularly right now. So we've got our contact information up there, and encourage you to reach out if you or someone you know is in need of mental health services. And just like Renee mentioned earlier, those services are available as a standalone service. And they're also offered at CDAC, which is our downtown location, if that's a more convenient location for a client. Our outpatient substance use disorder services, contact information is also there. And I want to leave lots of room for questions, so I'm going to go ahead and go to the next slide. Like we said, there are no assessments needed to get into residential treatment. Our admissions team is ready to take a call. They're ready to read that fax, or however somebody is making a referral. We're going to be there. We're going to help in every step of the way. Just recently, we had a client who needed housing before we could get her insurance to authorize to get her into treatment. She's, we were able to help accommodate that, get her assessed quickly for her insurance, help her with support with food, get her connected to peer support, provide transportation, all of these things. And it all started with our residential admissions team. So we're super grateful for the support that they're able to give. With that, I just want to hand it back over to Renee. Thanks.
Yeah, thank you, Tara. Danny, you can go to our last slide here, and then we'll wrap up for questions. We love to hear from people. So if you're a provider or would like to potentially refer folks to us, a great path is to join our e-newsletter and let us know that's what you're interested in, because Tara sends out frequent emails about bed availability. And we also share, even if you're just interested in staying in touch with the organization and the industry, we have quarterly newsletters where we're sharing updates about what we're doing and sort of what's happening in our community. And then lastly, we love to tour people at our facilities because we're really proud of what we do. And if you would like a tour of any of our facilities or just to talk more with us, please reach out. And I know Danny will share our contact information when she shares these slides. So Danny, I'm going to pass it back to you to help facilitate any questions that folks have.
Thank you so much, Renee, Tara, and Cassidy. We really appreciate that. That was a lovely. So I love seeing the familiar faces from Triumph. They're a valued partner for us, and so it's just wonderful to hear more. I'm gonna just pull up the chat here and see if there were any questions in the chat, and then if you have a question for either the Triumph team or we can also ask Amanda and Mike questions at this time as well. Go ahead and you can either put those in the chat or raise your hand.
I don't have a question, but I cannot be quiet because I don't know how to do that. I appreciate seeing all the smiling faces on there and putting real stories to all the hard work that you're doing and be able to see that impact. So thank you for sharing that with all of us. What you're doing is huge, and it's so amazing that you're doing all these wraparound services and providing all this advocacy and understanding that it takes a lot of support and effort to support our communities that need a lot of love. So thank you.
I'm just checking the chat. Everett from Blue Mountain Heart to Heart says thank you for your work. So thank you, Everett. And yeah, I think with that, if there's no other questions, we'll go ahead and wrap up for the day. We really appreciate everyone's attendance and participation today. We just love having these collaboratives each month. And so I will, if you would like to get in touch with me, if you're interested in participating in the collaborative in any way, feel free to reach out. We will send out these slides with all this contact information after the event today. And then I just wanted to do a quick shout out and let you know that next month, in lieu of the Learning Collaborative, we are doing our mobile integrated health symposium. So our mobile integrated health program, also previously referred to as our community paramedicine program, is just doing phenomenal work, and we're bringing together all of our community paramedics, community-based workers, and other team members, as well as anyone who's interested in learning more about the field of mobile integrated health, coming up in person at the end of the month of next month. So it is a free event. You can register at the QR code here or reach out if you have questions. But if you are even remotely interested in this field, this event is right for you. You don't have to be in any particular position or with any particular organization. So we are looking forward to that wonderful event. And other than that, I will just say thank you once more to our presenters and have a wonderful day. Oh, I will share one more time the link to the post survey. If you have any comments, feedback, or requests for future topics, we would love to get those from you. And again, here's a QR code. And yeah, that is all we have for today. Thank you so much.
Thanks, Danny. Thanks, everyone.
Thank you.
Thanks, Danny.
Thanks, Tara. I'll see you soon.
Thank you for being a great slide sharer, Danny. We appreciate
Thank you. Yes, I got every one. I went to every slide, so I feel like I did a mission accomplished.
Absolutely. Have a wonderful day. We'll see you soon.
Yes, good to see you, Renee. We'll talk to you soon. Bye.